discussed introductory session about thyroid disorder. If you remember, I mentioned about how thyroid hormones undergo regulations, the physiological function of thyroid hormone. Then I also highlighted about some of the diagnostic tests we are going to use in the diagnosis of thyroid disorder. So today we are still continue with the same, but most importantly, we are focusing about the clinical aspect of thyroid disorder in today's session. So as I mentioned in the previous session, thyroid disorder can be classified into different categories, but majorly hypo and hyperthyroidisms are the most common type of thyroid disorder. But still, we can have thyroiditis, thyroid nodules, as well as thyroid cancer. So those are the thyroid disorder we'll encounter in the clinical practice. I hope I mentioned about hyperthyroidism. So the term itself is self-explanatory. So like too much of the hormone in the blood, and this ultimately increases the body's energy metabolism. So this condition is like the body is actually in high metabolic state. So you'll see the patient is actually very lean. Then the skin is very moist. Then you will see actually you are feeling hot in the extremities when you are shaking hands. Then, when you look at the causes, as I mentioned in the previous lesson, even Graves' disease is like the most common. This is just an autoimmune condition that can produce antibodies against to the thyroid hormone, but the effect is mostly stimulating, does not cause any significant destruction. So we have seen even some of the clinical parameter, but we'll discuss in detail when we are discussing about hyperthyroidism separately. Then we have also mentioned hypothyroidism. So still the most common cause of hypothyroidism is like an autoimmune destruction of the gland. It's mostly the most common causes in developed countries is Hashimoto's thyroiditis are the most common. It is just like an antibody will be produced to distract the thyroid gland, so the gland is no longer producing the hormone. Then, apart from that, we have seen about some other causes of hypothyroidism. Remember, radioactive iodine treatment, that is radiopharmaceutical. Maybe when you do this one for hyperthyroidism, the patient can have like permanent hypothyroidism. Then surgical resection, thyroidectomy or surgical removal of the gland can also cause even hypothyroidism. Of course, radiation therapy can also cause, and we have mentioned some medication that are responsible to cause hypothyroidism. Then clinically, those are the major features, and we have mentioned because of low energy metabolism, you will see the patient is feeling cold and there is weight gain, especially the cholesterol level accumulation is significantly very high. Then we have mentioned also TSH is the most sensitive assay in the diagnosis of thyroid disorder because whether the patient is having very mild or subclinical thyroid disorder, TSH can actually is usually very good. Because of this reason, TSH is like the primary test that should be done in the diagnosis of thyroid disorder. Then hypothyroidism can sometimes be temporary, but most of the time it is lifelong. Yeah, it is just lifelong. We have seen about thyroiditis. It is an inflammation of the gland. So what will happen in case where the thyroid gland undergo inflammation? So what will happen when the thyroid gland undergo inflammation? It can actually even cause hyperthyroidism. So when it undergo inflammation, there is actually release of the hormone into the serum. Then hyperthyroidism can also common. But mostly when there is a chronic inflammatory condition that is long term, that can cause long term destruction of the gland, this eventually causes hypothyroidism. So remember, thyroiditis does not necessarily mean it causes hyperthyroidism all the time, but there is a transient hyperthyroidism state. Then after that, when there is a continuous destruction, the patient will uh, end up having hypothyroidism. That is what we have seen, and this Hashimoto's thyroiditis is actually the most common because of continuous destruction of the thyroid gland. Okay, then the most common cause of thyroiditis is this one, which is long-term autoimmune condition. This often causes a gradual damage to the gland, and then finally the patient will have a permanent low level of thyroid hormone. So currently, there is no standard way to prevent the loss of destruction because of autoimmune condition. So we don't have any standard way. So the only way is we just normally give replacement therapy when the hormone is significantly low in the serum. That is the only strategies we're having in the market in the prevention of inflammatory condition in the thyroid gland. Then nodules are not, they are okay, but there are so many patients who is actually having nodules. Those are actually small lumps within the gland, but it does not significantly cause, most of the time, the patient is usually asymptomatic, but they do have some nodules or lumps within the gland. So it is very common and usually increases with age, and most of them are actually non-cancerous or benign in nature. So you can actually even see epidemiologically, usually do not cause problem, but about 5 to 10% may become cancerous. Unless and otherwise, most of the nodules are actually they are friendly, so they don't cause any clinical feature or any clinical presentation to the patient. But it is good to actually test the nodule, because some nodules can actually become cancerous after some period of time. That is why ultrasound of the neck is very important, and mostly fine needle aspiration or biopsy is very common. I don't know whether you have seen about this FNA. Huh? So this is a pathology test. So what they do is normally they will take blood sample from the site of the lesion, or that is from the tumor or from the site of the nodule. Then they actually look at whether there is a malignant transformation in the nodule or not. We call it is fine needle aspiration, because they are using a needle. That is why it is called fine needle aspiration from the site of the nodule. Okay, if a nodule is benign, mostly treatment is not required, but sometimes this nodule can grow large enough and it can actually cause symptom, mostly like difficulty in swallowing and breathing because of anatomical suppression or physical blockage. Yeah? So because of this reason, sometimes we need to do surgery. So it is just up to the surgeon to decide depending on the anatomical blockage. So if there is anatomical blockage, that is when we are going to consider surgery for nodules. By the way, even in hypothyroidism, surgery is not a primary treatment in hypothyroidism. But when there is a massive swelling in the neck because of hyperplasia of the gland and it suppresses the trachea, and if the patient is having difficulty swallowing, now that is the time when we are going to consider surgery. Otherwise, in hypothyroid individual, because the problem is actually reduction in the synthesis of the hormone, surgery is not a treatment of choice. So it is only in hypothyroidism we are going to conduct surgery. Even that surgery is usually the last resort, because the thyroid surgery is very complex because of the blood vessels toward the brain. So it usually requires like a very extreme precaution when they do surgery. So currently, they said before, there is no any medication that can reliably shrink the thyroid nodules. So mostly it is just surgery that can actually treat this condition. Okay, now let me take you about the epidemiology of thyroid disorder. Remember, thyroid disorder in developing countries are very common, and it affects like 5 to 15% of the population. You can actually even see how it is like prevalent. Like 5 out of 100% will have thyroid disorder, and it is very common in women. So, what do you think, by the way, why it is very common in women? Is very like prevalent. If you go to the thyroid endemic areas, you will see this problem is very common in endemic areas. So why it is very common in females? What do you think? Why it is very common in female? Okay, maybe another question. Is thyroid disorder very common in Kenya? Maybe an experience. Is thyroid disorder very common in Kenya? If so, which part of Kenya is mostly affected? Okay, maybe let me call her. Laura.
I think in the highlands.
Did Highland, which part? So can you maybe repeat? I didn't hear your response. Okay, Angela.
Yes.
So what do you think? Is it common in Kenya, maybe from your experience?
So I've just joined right now.
Oh, okay.
Yes.
Oh, sorry. Oh, then who else? Annette?
I think it's common in pregnant women. I think I've seen
Okay,
it
it is
in
common
a
in
woman. A
pregnant
woman
women.
who is pregnant. Yeah.
Do you know why it is common in pregnant women?
I think it's because women experience increase in hormones, a
Mm-hmm.
hormonal imbalance during pregnancy. So
Okay.
they get like hypo or hyperthyroidism.
Okay, good. Then I will come that one. It's very common in pregnant women, but the reason you mentioned is not correct, but I will come toward the end. Then, is it really common in Kenya, this condition? Okay, fine. I think you are still feeling the cold. That is why you are not talking. Okay, by the way, it's very common in women. So far, there is no clear evidence why it is very common in female. But what they are saying, like what most scholars agreed about the high prevalence of thyroid disorder in female is because autoimmune condition is very common in female. If you see SLE or even rheumatoid arthritis, it is very common in ladies. So remember, thyroid disorder is mostly associated with autoimmune condition. So because autoimmune condition is very high in female, and that is why it is very common in why that's why thyroid disorder is very common in female. Otherwise, there is no clear reason why thyroid disorder is very common in women, apart from this explanation. Okay, then when you look at the spectrum of the disease, there is a change in the shape and size of the gland. By the way, remember, the size of the gland might not change significantly for all patients. So there is an individual variation in terms of size and shape. Some they do have massive tumor, some very mild, but still they do have the disorder. So there is a change in size or shape of the gland. And apart from that, there is a difference in the secretion of the hormone from the gland. And remember, in developing countries, the major primary causes of thyroid disorder is like lack of iodine, from the diet. That is why iodizole is the primary therapy in treating goiter in majority of developing countries, and most of the cases are actually due to deficiency of dietary iodine. Then there is a need of screening of newborn for congenital hypothyroidism. As I mentioned before, uh, if the mother is actually having hypothyroidism, the probability of having mental retardation into the fetus or the infant is very high, and we call it cretinism. So remember, in the early life in the uterus, mostly the fetus is usually depend on the thyroid hormone from the mother, which is very important in the development of central nerve system, especially during the primary or the first trimester of pregnancy. So if the mother is having congenital hypothyroidism, the probability of having mental retardation after delivery is very high, and that is why immediate intervention should be done the moment they are born. But in general, or generally speaking, screening for newborn congenital hypothyroidism is generally recommended. Then, how do we came up with the diagnosis? And as I mentioned before, TSH is like the most sensitive bioassay for thyroid axis. So this is very sensitive, and it is usually even by itself it is adequate for the diagnosis of thyroid disorder. Then, as I mentioned in the previous lesson, depending on the etiologies like primary or secondary failure, uh, the if the patient is having high TSH, mostly it signifies hypothyroidism. If the TSH is actually very low, it usually signifies hyperthyroidism. And remember, this one is true when the patient is having primary glandular failure. If the problem is from the gland itself, we'll see high TSH signifies hypothyroidism and low signifies hyperthyroidism. I hope you know why TSH level is very low during hyperthyroidism. So why TSH is low during the primary hyperthyroidism? Surya, Surya, can you try?
Yes, sir.
Yes,
I
why?
think
Okay.
you've asked TSH low in primary hyperthyroidism.
Yes.
I think that's because when the TSH is produced by the pituitary, um, I think the as it's being produced, that means it's going to have um, high T3 and T4 produced, but now because wait. I think because it's being stimulated more, it's used more to produce the hormones in the thyroid. That's why in the serum it's going to be low. I think so.
Any other person? Tony?
Yes, sir.
So what do you think? Why it is low in hyperthyroidism?
I think this is where the thyroid is making too. Yeah, the thyroid is making too much of the hormone.
Then what will happen when the thyroid is making too much of the hormone?
This is where the hyperthyroidism happens.
I'm saying hyperthyroidism. So why TSH is level low when the thyroid is actually producing too much of the hormone T3 and T4? So why TSH is low? Okay, another person.
Because if the damage is on the thyroid gland,
Uh-huh,
it reduces the secretion of the hormone,
uh-huh.
but there's negative feedback. So the pituitary gland is stimulated to produce a lot of TSH, but the thyroid cannot because it's damaged.
Okay, so why TSH is low in hyper? Oh, that one is for hypothyroidism. Why it is low in hyperthyroidism?
In hyper, there's still a lot of production of the hormone,
Mm-hmm.
but now the negative feedback will cause the pituitary gland to produce less TSH.
Exactly. That is what I want to actually. I want to get answer from you like this. Huh? So the more you have, like the more the gland is producing T24. Now that means the negative feedback mechanism is actually tries to activate to inhibit the pituitary and the hypothalamus. So when you look at the effect on anterior pituitary, now the TSH level will be suppressed because of excessive negative feedback mechanism as a result of too much of the hormone. That is why this finding is usually low in hyperthyroidism. But remember, all parameters can be high in case if the patient is actually having pituitary tumor or maybe any problem in the hypothalamus, all the parameter can also be low, sorry, high, and all parameters can also be low. That one is usually true when a patient is having secondary or tertiary hypo and hyperthyroidism. So this is the normal reference range, and as you know, the reference range varies from lab parameters to lab parameter, but this is like the most common range for TSH level. Then you can see a patient, when we say a patient is having overt hypothyroidism, when the TSH level is actually above 10 milliunit per liter, and most of the time, if the TSH level is above 10 milliunit per international milliunit per liter, and most of the patients are actually symptomatic. So like the symptoms we have seen in the previous slides will appear and mostly. But if the level is actually between 2.5 to 10, and it is usually mild and subclinical, so the patient can be asymptomatic at this point. Okay, then the serum T4 and T3 levels can be used to assess thyroid function. By the way, if the patient cannot afford like to do all the thyroid function tests like T3, T4, and TSH, those are the most common tests. Antibodies really done. I have never seen when the clinicians are actually ordering. I don't know why. Maybe it is expensive or the tests are not available in the country. I never came across when they are actually doing for antibody test, especially for Graves' disease. But they usually look at T3, T4, and TSH. But remember, TSH is the most sensitive bioassay because when there is a significant derangement in the thyroid function, you will see a change despite the T3 and T4 levels are normal. So this one is more sensitive. But if the patient, it is good to check all of them. But in case if the patient cannot afford, you can do TSH alone. TSH alone is sufficient even for the diagnosis of thyroid disorder. But you mostly they start from TSH, then they continue T3 and T4, and some clinicians normally they order all of them. Okay, then T4 and T3, but T4 and T3 alone might not be used to assess the thyroid function, especially in terms of diagnosis. So you have to do TSH. If a patient is having mild hypothyroidism or hyperthyroidism, they might have a normal free T4 level despite there is an abnormal TSH level. That is the major problem, by the way. If a patient is actually having mild condition, the T3 and T4 level can be normal. That is why this test alone might not be sufficient to confirm the diagnosis of thyroid disorder because in the norm, it can be normal when the patient is having mild condition. So this is the parameter, this is the normal values, but now this time around, we just normally use the reference parameter, which was given by the institution, or from the lab facilities. So, but this is mostly the average free T4 level, 0.7 to 1.9 nanogram per deciliter. Some even they use picomole, some use nanogram. Okay, then. So this is how the test look like. As I mentioned before, TSH is the gold standard, but remember, it can be affected by dopamine agonists, glucocorticoids, and etc. I will come later. The anti-thyroid peroxidase antibodies and the thyroid stimulating receptor, thyroid stimulating hormone receptor antibodies are usually, this one is less than 100, that is the normal values, but this one is usually undetectable, and it's very common. If there is actually, if we notice a detectable amount of these antibodies in the serum, it confirms Graves' disease. As I said before, this test, those antibody test is not commonly done, but I don't know the reason why it is not commonly done. But this is very important so that you can rule out whether that thyroid dysfunction is due to autoimmune condition or not. So those are the most common tests that can be done when a patient is having a thyroid problem. But another test that can be considered but not common is radioactive iodine uptake. So this one, you actually give a patient radioactive iodine, so then he will swallow. Then after some time, you will see actually whether the thyroid gland is actually uptaking the radioactive iodine. So after you give, there is actually a camera that can actually detect the amount of radioactive material that is uptaken by the thyroid gland. So this is known as radioactive iodine uptake, and the normal finding is usually 3 to 6% at 6 hours and 8 to 25% 24 hours. And mostly, the higher the percentage means, for example, if the uptake is actually very high, it is usually elevated or high in hyperthyroid individual. So it is very important actually even to identify the presence of thyrotoxicosis due to non-thyroid gland sources. So this is, we call it thyroid scan or radioactive iodine uptake, not common test, but that is why I mentioned other diagnostic test. So coming to the point, hypothyroidism is the most common clinical disorders of thyroid function. Remember, in developing countries specifically, hypothyroidism is like the most common as compared to hyperthyroidism. So, and mostly it is due to inadequate secretion of the gland. And majority of the hypothyroid patients have primary gland failure. So, primary hypothyroidism is the most common type of thyroid disorder because most of the patient is actually having due to glandular failure. But remember, there is a possibility for a patient to have pituitary and hypothalamic failure, and this ultimately causes hypothyroidism. Then, what are the causes of hypothyroidism? What causes glandular failure? The first one is autoimmune destruction. The second one is maybe iatrogenic, radiation, surgery, excessive dose of antithyroid drug, and sometimes even drugs such as amiodarone and lithium. So those are the most common primary causes of hypothyroidism. Secondary causes due to hypopituitarism, tertiary due to failure of hypothalamus. So the word primary, secondary, and tertiary refers to primary is from the gland itself, secondary is the next, like the next control system, that is the anterior pituitary. The third one is tertiary, which is the hypothalamus. So if you see the hypothalamus pituitary and thyroid axis, HPT axis, can be affected, but the most common one is due to distraction from the primary gland itself. Okay, so those are some of the causes. Then remember, when a patient is having pituitary or hypothalamic failure, and mostly the patient will have all other signs such as hypogonadism. Hypogonadism and low level of TSH is very common when a patient is having this problem. Remember, if the pituitary is affected, means probably there is a possibility of problem in the gonad. Yes. Then, especially in the third world countries, this is iodine deficiency is another most common causes, including even congenital hypothyroidism in the neonate. And sometimes even the tissues can be resistant, like tissue insensitivity to the action of thyroid hormone. We call it peripheral hypothyroidism. Like despite very significant amount of the hormone, the tissue is not responding is for the action of the thyroid hormone. We call it peripheral hypothyroidism. So then, what are the clinical features of hypothyroidism? What are the clinical features of hypothyroidism? Can you try maybe, because we have mentioned maybe, what are the clinical features of hypothyroidism? Was he boring?
Yes,
Was he, give me one example, one clinical features of hypothyroidism.
I'm not sure.
You are not sure?
So I'm not feeling well.
Oh, okay, Polly. Yeah? Any other person, Patel?
Constipation.
Constipation, why?
I'm not sure why. I'm not so sure.
Okay, then Fabian?
There's tiredness, feeling cold.
Why they are feeling cold?
Because their metabolism is lower
Okay.
and slower.
Okay, good. Metabolism is lower, so they are feeling cold. Then Geoffrey? Geoffrey? Hey, please actively involved by the way. Yeah? At least you have seen normally the slides. Huh? It's just normally giving explanation. Why the sweating is reduced, why they do have poor memory, why they are actually having hearing loss, why they are depressed, why they are actually feeling puffy, why they are actually adding weight. Okay, those are the kind of things I want to know. Anyways, so thyroid disorder, they do have actually non-specific and gradual onset of presentation. You'll see a problem in the skin, and you will see even in the neuromuscular system. So in the skin is related to puffiness and cold intolerance. They are very intolerant to cold. That is very typical for hypothyroid individuals. And the skin is usually very cool because of the low energy metabolism. Then, as I mentioned before, thyroid hormone has involved in cognition and memory. So mostly poor memory and reduced cognition is very, they're actually feeling weak. That is dizziness, somnolence is actually very common. Then even depression is also very common. So psychiatric disturbances are also common when a patient is having this problem. Then, apart from that, the next presentation is metabolic abnormalities. Remember, there is actually reduced metabolism when a patient is having hypothyroidism. Specifically, the, the metabolism of cholesterol or clearance of LDL cholesterol is usually reduced. In short, cholesterol degradation will be reduced, and that is why cholesterol level is very high in hypothyroid individual. Then apart from that, they might have macrocytic anemia. Remember, when a patient is actually having thyroid disorder, and mostly the thyroid disorder is due to autoimmune condition. So as a result of autoimmune condition, it can actually affect the absorption of vitamin B12 and even folic acid. That is why macrocytic anemia comes in. And apart from that, thyroid hormones are also have some role in stimulation of the production of erythrocyte or RBCs. That is why anemia is also another finding in a patient who is having thyroid disorder. Then, when you look at the gastrointestinal feature, weight gain with decreased appetite is very very common. They actually gain weight because their metabolism is very low. Then the appetite is usually decreased. So despite the appetite is reduced, they actually still gain weight because of low metabolism. Then abdominal distension and ascites and constipations are very, very common. But most importantly, when you look at the effect on the cardiovascular system, the cardiac output is also reduced. Bradycardia and cardiomegaly is also another finding. That is why hypothyroidism can also is also one cause of heart failure. Yeah, because remember the effect on catecholamines is actually very high because thyroid hormones are involved in a generation of sensitivity or activating catecholamine so that the effect is significantly reduced and the patient will have bradycardia. So those are the most common clinical presentation when a patient is having a hypothyroidism. And remember, those are not specific and they are not conclusive for the diagnosis. And we need to do the TSH, T3, and T4 tests before we confirm the diagnosis. Investigation. When you look at the investigation of this condition, I've already mentioned like the free T4 and T3 levels are usually low, and the TSH level is usually high in the primary hypothyroidism. Okay, in secondary and tertiary, all the parameters can be low, as I mentioned in the previous class, and sometimes the free T4 level can be normal in mild condition. We have already mentioned in mild condition, like the T4 level can be normal, but usually the TSH is the most specific bioassay to detect even mild derangement. Okay, then what are some of the drugs that affect the thyroid function? Like some drugs can reduce the TSH secretion. Some drugs can reduce TSH secretion, like dopamine, glucocorticoid, and octreotide. Octreotide. Those are the drugs that can affect the TSH secretion. And of course, some of them, they can alter even thyroid hormone synthesis, like iodide and lithium. Like they can, for example, amiodarone can cause both hyper and hypothyroidism, and lithium usually causes hypothyroidism. So those are some of the drugs that can affect the thyroid hormone secretion. Some of them, they actually decrease the absorption of the hormone. So because of, for example, if you see ammonium-containing antacids like ferrous sulfate, ferrous supplements, calcium-containing food items, they can actually even decrease the T4 absorption. So when a patient is actually taking this class of drugs, we need to have a minimum of like 2 hour gap before and 4 to 6 hours after food. Otherwise, it can actually affect the absorption of the thyroxine, and mostly we need to give even high dose. Then, apart from that, other class of drugs alter the metabolism. Remember the enzyme inducers and the enzyme inhibitor. I hope you have covered in the general pharmacology enzyme inducers and enzyme inhibitor. For example, anti-epileptic drugs, phenobarbital and phenytoin, and rifampicin, anti-TB drugs, and carbamazepine, the anticonvulsant drugs or anti-epileptic drugs, they are very notorious to increase the metabolism of the hormone, so the patient will end up even having low T4 and T3 level. Yeah, that is why if a patient is actually chronically taking these drugs, you have to check even the thyroid function test. Is very, very important. Huh? Like most of the treatment is just lifelong, and you need to check whether there is any derangement in the thyroid hormone level. Yeah, that is true. Even anti-TB drugs, rifampicin is a very potent enzyme inducer, and it actually reduces the level of T4 and T3 in the serum because of enzyme induction. Okay, so those are some of the effect of drugs. Huh? So that is why the moment you see reduced thyroid hormone level, don't trust to conclude this is actually due to anatomic condition without actually looking all the parameters that can affect the hormone level. Then apart from that, some drugs they inhibit the conversion of T4 to T3, peripheral deiodinase. Deiodination can be inhibited by some drugs like beta blocker, propyltyrosine, even glucocorticoids can actually inhibit the conversion. Remember, T3 is the most physiologically active hormone. So if they reduce the conversion means probably the patient will have actually a lower T3 level can be achieved. So those are some of the kind of things you need to actually put in your mind when you encounter a patient who is having thyroid disorder. Are we together? Are we together?
Yes.
Okay, good. I hope we're following. You're following. Okay. Then we have mentioned about the scale of hypothyroidism, like cholesterol level can be elevated. Sometimes even dementia, like I said in the elderly, can also cause. Then, most importantly, uh, risk of miscarriage and developmental impairment in child is very common if there is a maternal hypothyroidism. Those are some of the major complications of hypothyroidism apart from what we have mentioned so far. Then finally, how do we treat hypothyroidism? The goal of therapy and the treatment is quite straightforward because the patient is a deficit of thyroid hormone, so we need to give replacement therapy. So the goal is we need to replace the missing hormone, resolve the clinical feature, then we need to achieve biochemical euthyroid state. Those are the goals of therapy when a patient is having this problem. Then treatment of hypothyroidism is mostly replacement therapy. Mostly we give thyroxine is the most common replacement therapy so that it can restore like every clinical features. So for all symptomatic hypothyroidism patients, there is a need of replacement therapy, and T4 is mostly the drug of choice except in severe form of hypothyroidism, we call it mixed edema coma. That is when we use T3 initially because it has rapid onset of action. Yes, because it has lower protein binding, T3 is relatively having rapid onset of action, and this is the active form of the drug. And we do have leothyronine, which is the synthetic form of T3. So levothyroxine, remember the dose of this drug should be depending on the age, severity, and duration of the illness, and even the existence of concurrent cardiac disease. And we have mentioned levothyroxine is having longer half-life because it is highly binded to protein and it can stay longer time up to 7 days in the serum. So once daily dose is sufficient. Yeah, almost in all cases, levothyroxine should be given like on once daily doses. If a patient is actually below 65 years with overt hypothyroidism, the average thyroxine replacement is usually 1.6 microgram per kg per day. That is the daily requirement. If a patient is having mild cases, we can start. In fact, this one is the most common replacement doses. 25 to 50 microgram uh, daily dose is the most common. But of course, if the patient is very older and having cardiac problem, lower doses are required. Yeah? We might supposed to use 12.5 even to 25 microgram daily doses is usually recommended. Remember, remember, before we change any doses of thyroxine, the patient is supposed to be on treatment at least for 6 to 8 weeks. Remember the drug steady state concentration. Huh? Remember steady state concentration, what you have seen in general pharmacology, the steady state concentration will depend on the half-life of the drug. That means the time it will take to reduce the concentration by half. So most of the time, levothyroxine is actually having longer half-life, that is approximately 7 days. So in order to achieve steady state concentration, at least you need to administer a minimum of 4 half-life time. 4 times 7, that is 28 days, a minimum of 4 weeks. So that is when we say the patient is actually having constant amount of thyroxine in the serum. So at the steady state concentration, we can say the concentration of the drug in the serum is relatively constant and will see maximum effect. So because of this reason, the patient is supposed to be on treatment a minimum of this period in order to change any dose of levothyroxine. So any test before that time is usually misleading and we need to consider. So that is when we are going to consider dose adjustment. So if we don't achieve the target TSH level, of course, we need to alter the dose by 10 to 20% from the initial doses. So this is how we are titrating the dose of the patient. Okay, and most of the patient condition is usually controlled with this dose. Yes, and apart from that, another point to note, because in pregnancy, the demand of levothyroxine is very high because thyroxine is like the fetus is usually depend on the thyroxine in the mother. We need to increase slightly higher doses is usually used in pregnant mother. If the mother is pregnant, of course, we need to give higher dose, like 25 to 50% as compared to the other individual. We need to increase dose because the demand is very high. Then available formulation in the market, we do have with 25 milligram strength, 50, 75. I think what is common and what I have seen is the 25 microgram strength is very common. This strength is very, very common, but in ways those are the available strengths of the tablet of levothyroxine. Then why levothyroxine is preferred? Because levothyroxine mimics the normal or the natural physiological of the gland. Remember, levothyroxine produces, the normal gland produces more of the T4, like 80% of the T4. So the moment we give a levothyroxine, we're actually mimicking the physiological concentration of the hormone. So this is just, that is one reason why we give levothyroxine. Then the peripheral tissue after that will convert T4 to T3 when needed based on metabolic demand. So if a patient is actually having difficulty to adhere once daily dose, maybe once weekly LT4 is safe and effective because the half-life time of levothyroxine is 7 days. So half-life time is very important, remember. It is a time when the concentration of the drug is reduced by 50%. So when we say the concentration of the drug reduced by 50%, we can say the drug is more of subtherapeutic. That is why we are going to administer another dose, So that is why if a patient is not adhering on daily doses, we can give actually weekly dose because it can stay for a week to reduce its concentration by 50%. Then the general recommendation, levothyroxine should be usually recommended when a patient is having overt hypothyroidism. When a patient is having overt hypothyroidism, maybe we can consider what? We can consider replacement therapy. But there is a lot of controversies, especially whether we are going to replace mild or subclinical condition, especially between the 2.5 and 10 milliunits per liter. So there is a lot of controversies, and there is no actually any evidence about the benefit of replacing treatment in subclinical individuals. So, but most clinicians agreed if the cholesterol level is high, if the antibody titers is high, most clinicians recommend treatment. If you notice all those parameters and the patient cholesterol level is high and the antibodies are present, you better replace instead of actually but generally there is no evidence about the outcomes of or the benefits of replacing treatment in mild patients. Another replacement therapy is leothyronine, that is T3. It is very fast onset of action and shorter half-life than levothyroxine, and is very potent, like 5 times more potent. And mainly it is usually indicated in severe form of hypothyroidism. We only use it in severe form of hypothyroidism. That is the most common indication. Otherwise, it is not very commonly used. So you can see the commonest strengths we're having 5, 25, 50 microgram. So usually, this is the most common doses we're using, and available in the form of injection as well as oral formulation. Okay, so this one not commonly used. Even myself I never came across T3, but it is available in the market. I think this one you can read, and this one is just about the dosing schedule for different population. Yeah, for elderly, how much we're going to use. For long-standing hypothyroidism, how much. For pregnant women, how do we titrate. For pediatric patients, how do we use. And remember, the onset of action usually occur 2 to 3 weeks after the treatment, and the maximum effect we can see is after the steady state concentration is achieved, that is after 4 to 6 weeks of treatment. Then how do we treat hypothyroidism in a special population? Remember, special population is pregnancy, children, and of course elderly patients. So in pregnancy, remember the beta core ionic gonadotropin, which is produced by the placenta, usually acts as a TSH receptor agonist. It is usually served as a TSH receptor agonist that can actually increase the amount of thyroid hormone, which is very important and available for fetal growth and development. So what is the role of human core ionic gonadotropic hormone? Does it have any diagnostic benefit? Does it have any diagnostic benefit? Marion? Marion, can
Pardon,
you?
sir. Pardon, sir. My internet logged me out.
Oh, okay. Can you hear now?
Yeah.
Okay. Do you know about the human core ionic gonadotropin? Does it have any diagnostic benefit?
Not that I know, because you said that we mostly use TSH and T4. So I'm not sure about the human.
In other condition, does it have any other benefit in other circumstances?
I'm not sure, sir.
Any other person who can try? Joyce?
No, sir, I have no idea.
Okay, Kangai. Okay, Kangai.
Not really.
You never.
Okay, I know, but I'm not sure.
You say cancer.
I think it's used for detection of pregnancy, like if you're pregnant.
Hey, thank you so much. Yeah, pregnancy it is. Remember, like I think 2 weeks after fertilization, the HCG level starts produced by the placenta, and we can detect pregnancy is usually detected by urine or serum level of HCG, which is very simple and straightforward. Yes. Then apart from that, someone mentioned about molar pregnancy. Yeah, molar pregnancy is also detected by HCG level. I think that one will come uh, uh, in which semester? In summer semester next year about this condition. Yeah, about the neoplastic or oncologic or malignancies. So molar pregnancy can be detected using human Quranic gonadotropin. But remember, that is why if a patient is actually having by the molar pregnancy, which is actually a type of abnormal pregnancy, which is mostly benign and cancerous, one of the findings is actually hyperthyroidism. Why hyperthyroidism? When they do have molar pregnancy, they are producing too much of HCG. Then this HCG will serve as a TSH receptor agonist. Then it actually produces more of the hormone, and the patient will end up having hyperthyroidism. That is why the moment you see hyperthyroidism, there are so many things that should come in your mind. It could be even molar pregnancy. It could be even malignancy in the thyroid gland. It could be any tumor in the anterior pituitary and etc. etc. So there are so many things. So that is why you need to actually increase your scope when you are actually investigating a patient. So this is like the physiological mechanism, how the body tries to avail sufficient amount of the hormone to get for the fetal growth and development. So that is why if maternal hypothyroidism is not treated, the possibility of intellectual capacity and miscarriage, like intellectual capacity defect and miscarriage is very, very, very common. That is why mostly if a patient is having, and that is why like it is good to assess the thyroid function test level in pregnancy. Then as someone said, why thyroid level is very high in pregnancy, why thyroid function or why thyroid problem is very common in pregnancy is either the demand is very high, that is why it is very uh, common problem. And apart from that, hyperthyroidism is very common in pregnancy is actually because of the effect of beta HCG, which is produced by the placenta, so that it activates TSH, and the patient will having what? T3 and T4 level will be elevated. That is one reason why pregnancy is really one of the most common cause of thyroid disorder. Then as I mentioned before, there is a need to increase the dose because the demand is usually very high. And then after delivery, now we need to reduce or we need to return the dose back to normal individual. So we just give higher dose, like slightly above 50%. Then after delivery, we need to retain the normal dose. For children, full replacement dose between 10 to 17 microgram per kg daily dose is usually recommended. Then if the child is not able to swallow the tablet, recommendation is you just crush the tablet, mix with breast milk, and then you give them. Yeah. Then this is normal the dosing is scheduled. So by 6 months, we need to actually reduce the dose. Then from age to 1 to 10, then we can give this much dose. Then after age 12, adult doses can be given. So mostly slightly higher doses are usually given during children so that they don't encounter any mental retardation. Yeah. That is why that is recommended. Then the mixed edema coma is the severe form of hypothyroidism. Mostly it is life-threatening condition and the mortality rate is very high. In this circumstance, we need to give like intravenous injection of LT4. Sometimes even T3 can be administered because it has actually more rapid onset of action. So in this condition, if the patient is having severe symptoms of long-standing hypothyroidism, maybe we need to consider intravenous therapy is one of the recommendations in this case. Then finally, what are the major ADRs of levothyroxine? But that is one role of the pharmacist, like the aspect of pharmacovigilance or detecting any unwanted or undesired effects of the drug is one of the major role of the pharmacist, especially in the oncology areas. That is really very critical, and we need to actually even give much emphasis about this in that circumstances. So ADR detection is very important. That is why, as much as the pharmacist, we are supposed to know at least the major adverse effects of each class of drug is what we have in the pharmacy. Nervousness is very common. So like the clinical features of hyperthyroidism will happen when we give levothyroxine. Of course, palpitation and tachycardia can be happen. This is because of the effect on the heart. Then heat intolerance is very common, and unexplained weight loss is just because of excessive metabolism. The patient can have like unexplained weight loss might be happen. Then finally, how do we monitor? Monitoring is very important, and usually TSH is the most sensitive monitoring parameter, as I mentioned before, and a minimum of, as I mentioned before we adjust the dose, make sure the patient has been treated a minimum of this duration, otherwise the result would be misleading. Then after that, if the patient is actually stable, then initially you have to measure the thyroid function is every 2 to 8 weeks. Then after that, you can actually give them, you can check them every 6 months. After those stabilization, then you check annually thereafter. But then if the patient is stable, frequent monitoring is not really mandatory to conduct. So that is how we are treating and we are actually managing hypothyroid individual. So the home tech message is you need to know what is hypothyroidism, what are the major cause of hypothyroidism, what are the most common clinical features, and how do we treat and how do we monitor. Those are very key parameter. As usual, I don't know about your connection. I don't know whether you allow me to see this short video, 5 minutes together, or maybe let me hear your opinion. In case if you are using data, I will consume your bundle because of the video. So maybe can I display, or you just can see on your own time? Maybe I don't know about what kind of connection you are using. Can I display as a summary, or can we watch the video together, or you will have, or you might have some problem with the bundle? Maybe can I receive your opinion, please?
Maybe we can watch it together.
We can watch it together. Is it okay?
Yeah.
That will be the end of the session, by the way. After like the next 5 minutes, then we'll see together. That is a brief summary. I think some of the comments that are given from the sex portal is just normally. Most of you like normally the video we used to have it during that parasitic class in the fall semester last year. Okay, fine. So I will display it so that you can actually see it together. It's very good summary. So let me share. Let me stop sharing, then I share. Can you see my screen?
Yes.
Can you hear the audio?
No.
You cannot hear the video?
No.
Okay, so that means I have to go to. Okay. Stop sharing, then I share. Yes, computer sound. Okay, I forgot to share computer sound. I think by now you can see the video now, yes?
No.
Okay.
Hi, this is Tom from
Can you hear
ZeroToFinals.com.
right now?
In this video, I'm going to be talking about hypothyroidism. You can
Okay.
find written notes on this topic at ZeroToFinals.com/hypothyroidism or in the endocrinology section of the Zero to Finals medicine book. Let's jump straight in. Hypothyroidism is the term used to describe inadequate output of thyroid hormones by the thyroid gland. There's a few different causes. The most common cause of hypothyroidism in the developed world is Hashimoto's thyroiditis. And this is caused by autoimmune inflammation of the thyroid gland, so the body's immune system attacking the thyroid gland. It's associated with antithyroid peroxidase or anti-TPO antibodies, and also with anti-thyroglobulin antibodies. Initially, it causes a bit of a goiter, after which there's atrophy of the thyroid gland as the hypothyroidism sets in. Iodine deficiency is the most common cause of hypothyroidism in the developing world, and this is because iodine is essential for the production of thyroid hormones. Iodine is added to foods like table salt to prevent iodine deficiency and to prevent hypothyroidism. Hypothyroidism can also occur as a result of treatment for hyperthyroidism. So all the treatments for hypothyroidism have the potential to overshoot and cause hypothyroidism. So these are treatments like carbimazole, propylthiouracil, radioactive iodine, and of course thyroid surgery. There are also medications that can cause hypothyroidism. Lithium inhibits the production of thyroid hormones in the thyroid gland, and so can cause a goiter and hypothyroidism. Amiodarone interferes with the thyroid hormone production and metabolism, and usually it causes a hypothyroidism, but it can also cause a thyrotoxicosis. There's also secondary causes of hypothyroidism, or central causes, and this is where the pituitary gland is failing to produce enough TSH. And this is often associated with a lack of other pituitary hormones as well, such as ACTH. And this is called hypopituitarism, and it has quite a few different causes. And these causes can be tumours of the pituitary gland, infections in that area, vascular pathology, such as something called Sheehan syndrome, where you get pituitary necrosis after massive blood loss during childbirth, and radiation therapy to the pituitary gland. So how do patients with hypothyroidism present? Well, they can present with weight gain, fatigue, dry skin, coarse hair and hair loss. They can have fluid retention, so they can develop edema or pleural effusions or ascites. They can have amenorrhea, so their periods stop, and it can slow down the bowels and make them very constipated. So when you suspect hypothyroidism, how do you investigate them? Well, firstly, you would do a TSH, find that the TSH is abnormal, and then do T3 and T4 levels. In primary hypothyroidism, this is caused by a thyroid gland insufficiency. So the thyroid hormones like T3 and T4 will be low, and the TSH level will be high because there's no negative feedback to the pituitary gland. So the pituitary produces lots of TSH to try and get the thyroid working again. In secondary hypothyroidism, it's caused by pituitary pathology, and that results in a low production of TSH. So TSH will be low and the thyroid hormones will be low. How do we manage hypothyroidism? Well, it's quite straightforward. We simply replace the thyroid hormone that isn't there with oral levothyroxine. So we give them oral thyroid hormone in the form of levothyroxine. Levothyroxine is synthetic T4, and it metabolizes in the body to T3, so you get T4 and T3 from this one medication. The doses are titrated until TSH levels are normal, so when you start levothyroxine, initially measure the TSH levels monthly until the TSH level is stable, and then once stable it can be checked less frequently unless the patient becomes symptomatic. So if the TSH level is high, you know the dose of levothyroxine is too low, so it needs to be increased. And if the TSH level is low, you know that the dose of levothyroxine is too high and it needs to be reduced. So thanks for watching. I hope you found this video helpful. If you did, don't forget There's plenty of other.
Okay, fine. So this is all about the summary. Maybe now in the next few minutes, let me receive if you have any question or any clarification about what we have discussed so far. Any question? Any question? Okay, fine. So I think if you don't have question, let me stop.
Why is hypothyroidism associated with constipation and hyperthyroidism associated with diarrhea?
Sorry, can you repeat? I think your microphone is a bit far.
Why is hypothyroidism associated with constipation and hyperthyroidism associated with diarrhea?
Oh, okay. Good question, by the way. Yeah. Remember what we have discussed about the effect of thyroid hormone on GIT. Thyroid hormone usually have some effect on GI motility. So if the patient is having hyperthyroidism or high level of thyroid hormone means it actually increases motility of the GIT and ultimately causes diarrhea. But if a patient is actually having a low thyroid hormone, the opposite effect can actually occur. Like it actually hinder some of the motility because it is actually involved with some, it has actually some physiological effect on the motility of GIT. So it will have the opposite effect when the patient is having deficiency. So that means motility will be reduced. So the patient will encounter having constipation.
Okay, thank you.
Any other issues? Okay, fine. So let me stop here. I don't know. By the way, did you manage to see the material on the blackboard? Was it available?
Yes.
Oh, so it is available. Okay. Okay, Sawa. Thank you so much.
Thank you.
So see you next week. I think next week we'll still continue hyperthyroidism, but make sure you read